Penny, it is showing that you, I just read your text. It is showing that you didn't do it. Yeah, I don't have a score for you for it, but
Okay.
I'm going to check one other place. So give me 1 second here. Because it's kind of a little weird. So I'm gonna just see one other place. Yeah, it's not showing that you did it.
Okay, I just wasn't sure. It was confusing because I saw like the quiz still wasn't due yet, and I thought it was due, and then like I think you changed the date of the quiz of chapter 15, so I was just confused about that. And I don't know, I thought for some reason I thought that I had already done it, and
Well,
I thought
it says at some point you started it. At some point you started it, but whether you opened it, and it was like at a little after midnight on the 26th.
That's so weird. I don't know. I could have sworn I thought it would. I had already done it. That's why it was very confusing. And then when I saw that it was a 0, I was pretty upset because I really thought I did it.
Yeah, it says that you opened it like around 8:07 on the 24th of April. And so just the other day.
So when was it due then?
I need to look. I can't tell you right off the top of my head. But then you closed it and finished it on the 26th. So yesterday at a little after midnight. So just barely after 12 at 12:10 in the morning on the 26th. So do you know where you were? Tuesday morning at 12:10, right after midnight on Monday night?
I don't recall doing it at that time. That's why it's just really confused. Like that's really weird. I don't understand. I feel like something must have messed up somewhere there because that's just really weird.
That is kind of weird. That is really weird. Let me so it was due on the 25th. And that's probably why it closed it out on you.
Okay.
But give me 1 second here. Bear with me just for one more moment. Okay, so I'm just going to open it until next Tuesday night at midnight. So May 3rd.
Okay, thank you. Yeah, I just don't understand what happened with that because I know that I wouldn't have just like opened it and not done anything. Like it just doesn't make any sense. So it would have been 0 because I would have at least worked on it. Like I mean, I get interrupted constantly by my kids, so that's why like I work at it little by little. But like I know for sure I would have just not done. I wouldn't have just not done any, and I'm pretty sure I finished it. So I don't know. But thank you for opening.
If when you go into your when you go into your Connect, if it shows that it's done, which it may do that, if it shows that it's done, send me a screenshot showing you've completed it, and I'll put the score into D2L.
Okay, sounds good.
Because
Thank you.
occasionally there's just something weird, and online stuff is great until it's not. And so if it shows that you've done it, just send me a screenshot showing the assignment and the score, and,
Okay.
and I'll put the score into D2L.
Okay, thank you.
You're welcome. Outside of that, any questions or concerns?
Professor Gessel, my mom's here with me. Does
I see that.
does she have to log in separately for attendance purposes, or? Okay.
No. You know what? I'll tell you, I only take attendance like the first week. If I notice that someone is not here, like recurrently, like every week, I notice. But internet issues and everything else, I'm not gonna take attendance every night. And after watching people try to manage their kids while we have class, you gotta cut people slack. Let's jump into tonight's one, because this is the last time we are meeting. Make sure that you have turned in the case studies. No, I have not graded them yet. But if you do not turn them in, you will get a 0 score. So make sure they're turned in. Because
when we have to turn them in by, I didn't mean to interrupt you.
Turn them in. I'm trying to remember when my grades are due at Hack. Oh God. Bear with me. I think I have it on my phone.
I have 5-6 written down. I think that's what it says in
that. But that isn't that. Maybe that's probably a good deadline. I'm trying to remember when my grades have to be submitted.
Okay.
Give me 1 second, and I'll tell you if I wrote it down, if I actually recorded it, which a lot of times I do. No, I didn't, and I think it's around the 9th. So that's why I have things being due on the 6th. It might be the 11th. I honestly, I just can't remember. I think their grades at Hack tend to be due on a Monday morning. And so chances are they're going to be due not next Monday morning, but the following Monday morning, and they're usually due at like 9 in the morning. And so what I shoot for having them in by the end of next weekend. And what I will is I will send out an email when I have all of the case studies graded. I'm going to send out an email and say, look at your grades and make sure that they're correct. Make sure that all your scores are there on D2L. And I'll warn you, I'll put in that same email, I'll say, I'm going to be submitting grades within the next few hours. I do not do well under pressure. And so I try really hard not to put myself under pressure, which means that I try really hard not to procrastinate. And so I will get my grades in way before when they're due, or try. So usually within 24 hours of when they're due, I get them submitted. And so I'll send you an email and be looking for that email. And it will say, I've got your grades. Your grades are as complete as I know them to be right now. please look at them and make sure we're in agreement. And that will probably be next weekend. Is that clear?
Yes, thank you.
Yes, isn't the final due on May 9th, like the comprehensive final? Isn't that?
Will you give me, you know what, let me see when my final grades are due, because I just don't, I put it in my phone because I know I won't remember. And because I would teach for 3 schools, they're all different due dates.
Right. I feel like that's what the D2L says. So I wasn't sure if that was like midnight or what.
It would probably be at midnight because that's what I would do. I wouldn't change that around. But I'm going to look really quick. Why am I pulling up another email? I don't know. www. And they may not have even said it, but it's usually on a Monday. So I'm just looking at my email because it will say in there when they're new, usually. Final grades due. Final grades. Not that one. That was December. Final grades. You may start entering grades May 2nd. They have to be in by the 16th. So yes, turn them in by the 9th. Let's shoot for the 9th. If something happens and it doesn't work, let me know. But shoot for the 9th. Bear with. I knew it was going to be a Monday. I just couldn't remember when. But I knew it wasn't late in the day. I'm sorry, be patient with me for 1 second. I'm just plugging the date into my phone. And I will definitely have them in that day. I have a dental appointment that morning in Frederick. So I've got to, they'll be in by Sunday night. Let's see here, Pete. So I will have them in. I will work to have them in by Saturday. Sometime between Saturday and Sunday. But they have to be in by Monday at noon. And I can change them up until, if I remember right, I can change them up until noon, and then it requires a lot more work. Any other questions like that?
What's the magic A number again? I know we talked about that a while ago, like as far as the point number. We talked about the number, and we had like a number, and I wrote it down somewhere and I can't remember.
Magic A number.
Like the number of points that we want to reach to really do well.
Syllabus. Let's look at the syllabus. So I think, yeah, hack works. There's no A minuses, there's no B pluses, there's no B minuses. 100 to 90% is an A. 80 to 89 is a B. If you are at 89.6, I'll round it up. If you're, actually, no, let me just get really close to somewhere. It's hard to draw a line when it comes to that kind of stuff, so I'm not going to try. But I'll tell you what you have to have for an A. As professors, we want to round up, but there's a line to where you cannot round up. And so it's just get as close as you can. Times 0.9. So you have to have, for an A, you have to have an 1100, excuse me, as my dog chokes on my lap. You have to have 1125 points.
That's the one. Thank you so much.
You're welcome. Other questions? Okay, let's jump into tonight. Oh, Louis, no, stop, buddy. I didn't lock her out either. I know I didn't. You know who I'm referring to, my mother, because my dog is starting to growl and bark. Louis, I know I didn't lock her out.
I was locked out last night, but luckily the dogs were still out back, so they saved me.
They
Yeah,
well,
I knew I could go in through the back then. My husband locked the front door when I was doing stuff in the garden.
he's got quite the ferocious bark. And he's actually, my mother took him to the vet for the first time the other day, and we realized we thought he was 8 months old. He's actually 2. And he was actually really good the whole time. And they kept complimenting my mom on the fact that he was a rescue and he was so well behaved. But I think a lot of that is his temperament. So he sounds really ferocious, but he's really not. So lab exercise 14, skeletal muscles, identification and their actions. One, there's some general terms here. We've talked about flexion and extension. If you remember when we talked about joints. So flexion meaning a decrease in the angle between the bones at a joint. An example would be flexing of the arm at the elbow is going to bend the arm. Extension, increasing the angle between the bones at a joint. Skeletal muscles often will function as groups. where the muscle that causes the main action and does the majority of the work is the agonist or the prime mover. Muscles that will assist the prime mover are called synergists. Muscles that oppose the action are called antagonists. For example, all of your quads, quadriceps femoris, quadriceps lateralis, quadriceps medialis, and quadriceps intermedius are all synergists of being able to extend your leg at your knee. What are the antagonists for that action? And I know you may not know the specific names, but what are the antagonists? Where your quads, meaning on the front of your leg, of your anterior part of your femur. What are the antagonists?
Would that be the hamstrings?
Yeah, the hamstrings. And we'll talk about the specific names for the hamstrings, but when you think of it, recognize that they're working in groups, whether they're antagonistic groups or working together. So relationships between muscles depends on their action. A muscle can be a synergist for one action and an antagonist of another action. One of the easiest ways to be able to determine the origins and the actions of muscles is a lot of times to look at their origins and insertions. You aren't going to be asked as a general rule. There's some exceptions, and I'll show you there's easy exceptions. I'm not going to ask you to memorize and remember origins and insertions. The actions are important. However, in many times, the origins and the insertions relate to the actions. And I'll bet you Justin's Alan can tell you all about this, but
He had to learn every insertion and every origin of every muscle in the body.
I did too. You know, schools aren't making them do it. Stevenson University doesn't make them do it. I had to too. My students that I first taught A&P to at Idaho State University had to too. But we're realizing that that doesn't matter as much anymore. And we more care about the fact that you can identify the muscles and know their actions. However, as Justin's Alan can probably testify to, origins, when you flex a muscle or contract a muscle, origins don't tend to move. It's the insertion points that move. And so if you know the origin and you know the insertion, if you can determine what that insertion will do when the muscle pulls on that insertion, you can determine what the action is. So for example, the biceps brachii inserts on the coracoid process of the scapula, originates on the coracoid process of the scapula and the superior edge of the glenoid labrum. Actually, it's not the labrum, the superior part of the glenoid cavity, meaning right up here. And feel free to let Alan correct me if he's there, Justin, because I don't remember them all. But the insertion point is the radial tuberosity on the radius. So with my very not so manly biceps. I'm working on them. I actually have not worked out the last 2 Saturdays. But here's your biceps right here. And it inserts on the coracoid process and the superior edge of the glenoid cavity. It originates there and it inserts on the radial tuberosity. So when I contract my biceps brachii, what bone moves? It's not my scapula and it's not my humerus. It's my radius, right? So if I can describe what this action is, meaning I'm flexing my elbow, flexing my arm at the elbow, that's the action. I don't have to memorize it. I just know that's what this is. So a lot of this is memorization. A lot of it isn't. Some of it is not. Some of it is just looking at it, and I am not a kinesiology specialist. I wish I was. My brother-in-law, who I would really like to see teach A&P at some point, is he does the Superman bionic, whatever they call it, Superman races, where they go and they run and they bike and they swim and they run through tunnels and they climb up things. What are they called?
Yeah, Iron Man, or like
Iron
those
Man. That's what he
ninja
does.
races.
So he does the Iron Man, and he has a master's in kinesiology and exercise science. And so he will sometimes try to explain kinesiology to me. It doesn't work really well. I struggle with the spatial part of it. However, he's very good. He owns a gym, and he's very good at training other people how to enhance their performance. And what doesn't work with physical therapy, and why people should not wear, why it's more important for you not to wear shoes, and it's more important for you not to wear shoes unless there's a special reason for it. You should try to go barefoot as often as possible. And these are all things that he understands why and the function of. I'm not there yet. However, when it comes to knowing the actions of muscles, that's kinesiology, the movements. So we'll work on it here. But if you plan on going into physical therapy, if you plan on going into massage therapy, if it's something you've ever been interested in, knowing the actions of muscles is critical. So let's move forward. Actually, bear with me. One more thing. So muscle names. Muscle names provide clues as to their identification, and they're named according to several criteria. What the action is. Your biceps brachii, well, okay, that's not for this one. Your extensor carpi radialis longus. It runs along the radius and it extends the wrist. No. Specific body region. He's so excited he finally came back. Specific body regions, biceps brachii. Called biceps because it lines the humerus. No, yes. Why is it called biceps brachii? Because that's the upper arm. Oh, you know what? Now I'm sorry, you guys. Today is not my day. Let me think for a second. Biceps brachii comes from the fact, the biceps comes from the fact that it has two origins. Brachii because it's the arm region. So the number of muscle attachments is the biceps part. Where it's located, the specific body region is the brachii region, the arm region. So another example, the triceps brachii has three origins, and it's on the back of the arm. Orientation of muscle fibers. Rectus femoris. That runs down the back of your leg. And because the fibers run straight, rectus means they run straight. Another one, external abdominal obliques. External because they're the most outer layer of your abdominal muscles on the sides. Abdominal because they're on the abdomen. And oblique because they run at an angle. Some muscles are named for shape and size. The deltoid muscle that comes like this and does this. Inserts on part of the clavicle, inserts on part of the scapula, inserts on the spine of the scapula, and comes down and inserts on the deltoid tuberosity. Sorry, it originates up here, it inserts down here. So, and deltoid means triangular or like a shield-like shape. Muscle heads, tendons of origins, what they look like, semitendinosus, semimembranosus, two of the hamstring muscles. So the three hamstrings are the rectus femoris, the semitendinosus, and the semimembranosus. We'll see them in a moment here. A major part of the semimembranosus, it looks like a membrane. It's a see-through membrane. The muscle that's on top of the semimembranosus is a semitendinosus. And it's because over half of the muscle looks like a big long tendon. So semitendinosus because over half of it looks like a tendon. So I want to watch a quick video about origins, actions, and names. I didn't mean to do that.
If you're in medical school, I can guarantee special day. We're doing a kinesiology video that sports medicine degree is finally about to pay off. So there are over 600 muscles in the human body, and they are a colossal pain in the butt to memorize. And really, just the names and location of these muscles are only one layer of overall anatomy. And if the purpose of this big old squishy sack of meat flesh is to move us to the world and let us pet puppies and support literally every system in our body, then we have to go a little bit deeper. So in this video, we're going to break down the 4 big concepts that you're going to come across when you pop open that anatomy book to the musculoskeletal section. Just the quickest of background first. This is a skeletal muscle. One of the 3 types of muscle in the body. In order to actually move anything, it needs to attach to your skeleton via tendons. One of those attachment sites is called the origin, while the other is its insertion. Unfortunately, while it would definitely make things simpler, we can't just call one like the distal tendon and the other the proximal tendon, because the labels are actually given off of motion. not location. In general, when the muscle contracts, it's the insertion point that moves toward the origin. Let's check out an example. This dude right here is the sternocleidomastoid, or the SCM, named so because of its origin and insertion. You have one point that hooks in at the sternum and a bit of the clavicle, and another that hooks in at the mastoid process of the skull. So to figure out which one is the origin and which one is the insertion, we have to take a look at it.
One other thing, they're often named origin to insertion. So sternocleidomastoid. The origin is the part of the clavicle and the manubrium of the sternum. The insertion point is the mastoid process. So sternocleidomastoid. Probably one of the easiest ones to remember the origins and insertions of.
Action, which isn't actually as straightforward as it seems. Here's my advice. When you're learning muscle actions, actually do the action. Feel your muscle contract underneath your fingers so that you can really build a mental picture of what's happening with that muscle contraction. And you'll definitely notice this as you go and read more. But like the description for my example muscle, the SCM, is embarrassingly drawn out. Ready? When it acts unilaterally, it provides contralateral cervical rotation and ipsilateral cervical flexion, and bilaterally cervical flexion, elevation of the sternum, and assistance in force inhalation. And all of that just says you have two SCMs. If you flex both of them at the same time, you'll bend your neck. If you only flex one, you'll end up rotating it as well. Again, perform the actions, avoid memorizing sentences. Or not, do you? Either way, in both cases, the chest remains pretty fixed while the skull is moving. So we label the mastoid process the insertion, while the sternum clavicle area is the origin. Now, the sternocleidomastoid is pretty straightforward since it's a really simple shape. But the same rule applies for funkier looking muscles like the pectoralis. The pec major, aka the Terry Crews, has a super wide origin, touching on everything from the sternum, ribs, clavicle, and some connective tissue. But its insertion is a spot.
So if I tell you that it's involved in adducting the arm, what would that do?
It pulls the arm back in.
It pulls the arm back in towards the midline. And where is its origins and where is its insertions? Where does it originate? Where does it insert?
So that would be the origin would be the sternum and clavicle.
And the insertion point is going to be on the, I think it's the intertubercular sulcus of the humerus. So right up here on the humerus. Because if I'm adducting the arm, I'm bringing it in, right? And so it's not this part. When I flex that muscle, it's not this part or contract the muscle, not this part that's moving, it's my arm that's moving.
On the humerus. And since the muscle's actions bring the humerus either forward or towards the body, its origin is that big chunk of medial tissue, and its insertion is on the humerus. And while it might seem like there are a ton of intricacies in memorizing these components of musculature, if you know the origins and insertions, you can usually figure out the actions and vice versa. Cool. So the last concept that you'll learn in this lesson usually is innervation. Some nerve had to be stimulated.
If you can remember the path of the nerves, and we didn't really spend a lot of time talking about passive nerves. But any time that a nerve has contact with a muscle, it's going to innervate that muscle. Anytime, if it runs through it, if it runs on top of it, if it runs in between two muscles, it's going to innervate both muscles.
In order to get that muscle to fire. And that nerve is the innervation. And you can think about innervation in two main ways. You can either write each muscle and nerve on a flashcard and brute force memorize it, or just picture what group of muscles that nerve matches up with. For example, the oculomotor nerve, one of those 12 cranial nerves, innervates a bunch of those muscles that move the eye. Again, brilliant example of anatomists being terrible neighbors. So why should you care? I mean, once you got the names of the muscle bellies, you should be golden, right? Well, dude, if you ever want to get into physical therapy or sports medicine, or even just start performing some of these therapies on yourself, then you're going to need to know eyes and nose in practice. In everything from stretching to strength exercise, having a solid foundation and some pretty precise anatomy is going to become essential. And having them available just to like pull out of your brain at a moment's notice really ends up saving some time as opposed to having to look all this stuff up. And if you want to continue learning about the human body and hanging out with him.
Any questions so far?
I'm going on it. I don't know.
So I will try to give you hints as to different ways to memorize certain muscles that I know. So muscles of the face and neck. The epicranial or epicranius or occipital frontalis. Remember, this is one that's named origin to insertion. So it originates on the occipital bone. It inserts on the skin right above the eyebrows or right underneath the eyebrows. And it's got two bellies. It's got a frontalis and an occipitalis belly. And they are attached by this epicranial aponeurosis. Aponeurosis meaning this sheet of connective tissue. Dense, irregular connective tissue in this case. Temporalis inserts around the temporal bone. Oh, actually, bear with me. Originates around the temporal bone and inserts underneath. Let me see here. All right. It inserts around the masseter. Excuse me, not masseter. The maxilla. If it originates up here and it inserts down here, what do you think it probably does? It helps you clench your jaw. The masseter muscle originates on the zygomatic arch and inserts underneath the maxilla. It's the major muscle involved in closing your jaw, elevating your jaw. However, the temporalis is a synergist of it. They work together here. Two zygomaticus, zygomaticus minor, zygomaticus major. The buccinator muscle, which if my mother wasn't around, I would tell you how I remember this one, but because she's around, I'm not going to tell you. Think Monica Lewinsky, and that's all I'm going to say. All I'm going to say. Orbicularis oris is the muscle that goes around the mouth. Oris because of mouth, orbicularis because it's circular in shape. Allows you to purse your lips. The kissing muscle. Orbicularis oculi, muscle that goes around the eye. allows you to close your eye. And open it. Open your eye. Sternocleidomastoid, like the man said in the video, muscle that attaches to me. Inserts on the mastoid process originates on the manubrium and the clavicle. Allows you to flex your neck towards the side of that muscle, to the left or to the right, depending on which muscle you're using, which one you're using. Platysma, I don't do it very well since my accident, but if you, it's on the allows you to tighten the skin under your chin. Trapezius makes a trapezium across the entire back. And we'll see it in a moment here. But it makes it looks like a trapezium across the entire upper back. So epicranius originates on the occipital bone, inserts on the skin around the eye or right around the eyebrow. Elevates the eyebrow. Orbicularis oculi, I think it's on already. You may have turned it off. Orbicularis oculi originates on the maxilla and the frontal bone and inserts on the skin around the eye, closing the eye. Orbicularis oris originates on the muscles near the mouth and inserts on the skin of the lips, as allowing you to close and protrude the lips. Buccinator originates on the alveolar processes on the maxilla and inserts on the orbicularis oris and allows you to compress your cheeks or to suck. Zygomaticus, there's two of them. There's a Zygomaticus minor and a Zygomaticus major. But they originate on the zygomatic bone and insert on the skin and muscle at the corner of the mouth, allowing you to elevate the corners of your mouth. Platysma looks like a plate, a flat plate that runs across your chin. That's the way that your chin and your neck. It's a very flat muscle. And so when I think of it, I think about a plate that would run down a thin plate that would run down your neck, from your chin down your neck. So it originates on the fascia of the upper chest and inserts on the skin and muscles below the mouth. Allows you to depress the lower lip and angle of the mouth. So depressor anguli oris, trying to think, did we see that here? You don't really see it right here, but it's right here. It's not labeled, right here. So depressor anguli oris, allowing you to frown or kind of pout. Not so much pouting, that's more depressor. Depressor labii inferioris. But depressor anguli oris is going to originate on the lower part of the mandible and insert on the skin at the corners of the mouth, allowing you to frown. Orbicularis oculi, allowing you to blink and close your eyes. Zygomaticus major, allowing you to smile by elevating the corners of your lips. Orbicularis oris allowing you to close your mouth or kiss. The frontal belly of the occipital frontalis allowing you to elevate the skin of your eyebrows and raise your eyebrows. And platysma being able to tense the skin of the neck. Questions so far? So like I went, if you take this in the schools, I'm trying to think, there are some schools here in Maryland that, and maybe Justin's people, they probably know about schools where they use cadavers here in Pennsylvania. I don't know of any right now. I know there's one in Maryland. However, all of the other schools use models. I don't think models do it justice sometimes. So this is comparing the two. Here's the frontal belly of the occipital frontalis. Here it is on the cadaver. Orbicularis oculi makes a circle around the eye. Orbicularis oris making a circle around the mouth. Zygomaticus minor and Zygomaticus major. You think about that zygomatic arch. It's coming across the zygoma. It's originating on the zygomatic arch. Both of them. Depressor anguli oris originates on the mandible, the lower edge of the mandible, inner edge of the mandible, and inserts on the corner of the lip. And it comes in at because it comes in at an angle, inserting on the corners, it's called the anguli oris, allowing you to depress the corners of your lips. I'm trying to remember if we talk, I think, yeah, actually, I'm gonna wait. I think we talk about it later. Levator labii superioris. Inserting on the muscle of the orbicularis oculi. No, originating there and inserting on the orbicularis oris around the lip, allowing you to elevate your upper lip. So levator labii allowing you to elevate your upper lip, and it's superioris because you have a levator labii, depressor labii inferioris down below. So depressor labii inferioris, right down here. I want you to really pout. Platysma, this one that's going to come all the way and make all, it's going to start up on the upper, actually, where is this? It originates down here, originates here and inserts here. And the reason I can tell you I don't have the origins and insertions memorized anymore. I did at one point, I don't have them now. But what I'm doing is thinking about the action. And I'm figuring out from thinking about what the action is, where's the origin and where's the insertion, because I know that the insertion is going to move. Most likely, and the origin will not. So because I think when you compress the platysma, it's going to suck the bottom of your chin down. This has to be the insertion up here, and this is the origin down here. And then in a moment, I think there's a list, and then I'll make sure that I'm actually right. But I'm pretty sure that's right. Mentalis. If you remember, there was a mental foramen right down here on your chin. Do you remember that? And it's kind of that thinking man pose where it's like, Mentalis is right down on the chin. Kind of also helping you to pout. Buccinator. Inserts on the bone right in front of the ear. No, originates there and inserts on the corners of the lip or the tissue of around the lips, allowing you to suck. So masseter muscle originates on the zygomatic arch and is going to insert on the lateral posterior surface of the mandible, allowing you to elevate and protract your mandible. Temporalis originates on the temporal bone and inserts on the coronoid process of the mandible, allowing you to elevate and retract the mandible. Masseter muscle. Your very strong chewing muscle allows you to masticate, chew. Temporalis comes through here and inserts on the coronoid process of the mandible. Originates here. Sternocleidomastoid inserts on the medial clavicle and the manubrium of the sternum. Originates there, sorry, and it inserts on the mastoid process of the temporal bone, allowing you to flex your head and neck towards the same side, rotate the head to the opposite side. Also is involved in forceful inhalation. Splenus capitis, semispinalis capitis, allowing you to rotate the head. Scalenes are another one that's involved in forceful inhalation. So the mastoid, sternocleidomastoid, originating on the medial clavicle and the manubrium, and inserting on the mastoid process. Pectoral girdle, so back of the shoulder area. Trapezius. This is the one, this is the weird one when it comes to origins and insertions, because it depends on how you contract it, which one moves. Whether the origins move or whether the insertions move, they can shift. So this is the one of the few muscles where you can't classify the action based on what moves when you contract it, because you can do a lot of things with this muscle. But the origin is the occipital bone, the spinous processes of the 7th cervical vertebrae and all the thoracic vertebrae. The insertion is the clavicle, the spine of the scapula, and the acromion process. Allows you to rotate and retract the scapula, elevate the scapula, or depress the scapula. Rhomboid major looks like a rhomboid in shape. Originates on the spinous processes of the upper thoracic vertebrae and inserts on the medial border of the scapula. Allows you to elevate and retract the scapula. Levator scapula, I don't know what it does. It allows you to elevate the scapula. I don't know. Allows you to say that. Elevate the scapula. Originates on the transverse process of the cervical vertebrae and inserts on the superior angle and the medial border of the scapula. Serratus anterior looks like a serrated knife across the ribs. If you think about what a serrated knife looks like it has little jagged ends. That's what this muscle looks like when it originates on the anterior surfaces of the ribs. And it inserts on the medial border of the scapula. Pectoralis minor, which is deep to pectoralis major, originates on the anterior surfaces of ribs 3 through 5 and inserts on the coronoid process of the scapula. Allows you to depress and protract the scapula and elevate the ribs during forceful inhalation. So I told you that the trapezius muscle makes a trapezium across the back. So it starts up here, it's down like this, moves down like this, and comes back up. It's probably one of the easiest muscles to be able to see because it's very superficial. And it looks like a trapezium across the back. The levator scapula binds to the superior angle of the scapula. Inserts on the superior angle of the scapula. Allows you to elevate the scapula. I don't know. And originates on the transverse processes of the C1 through C4 vertebrae. Rhomboid major and rhomboid minor, rhomboid major, rhomboid minor. Originate on the spinous processes and insert on the medial border of the scapula. Retracting the scapula. They're pretty superficial. They're, well, okay, they're not, they're deep to the trapezius. But as soon as you remove the trapezius, they're right there. So here's the trapezius here. And this is where it's removed on the other side to show the rhomboid major and rhomboid minor. No. Latissimus dorsi. I think this muscle is really easy to remember because it's a big muscle and it's very thin. I think of it as being a lattice across the back. Dorsi meaning back, latissimus dorsi. It's going to originate on the lumbar vertebrae and the thoracic vertebrae. It's going to insert on the humerus, allowing you to medially rotate your arm and adduct your arm. Deltoid originates on the spine of the scapula and on the clavicle. And on the medial lateral superior border of the scapula. And inserts on the deltoid tuberosity down here. Which if you look at people who are really well defined, you can see where it inserts and indents down into the muscle. If they have really well defined arms. Allowing you to extend your arm at the shoulder. Questions so far? So rectus abdominis, looking at the muscles of the anterior trunk. Rectus abdominis, this is the 6-pack muscle or 8-pack muscle. Works to compress the abdomen. External obliques, internal obliques. External obliques make a V coming down. Internal obliques make an A. External obliques and the external intercostals, meaning if you like to eat ribs, this is what you're eating, the external intercostals. Their fibers of the external intercostals and external obliques are continuous with one another. And they both make a V coming down. internal obliques and internal intercostals make an A going down. So if you can remember that, you can remember which ones they are, even if you're not sure. If you can see the direction of the way the fibers are running, externals are going to make a V, internals are going to make an A. Rectus abdominis, because it's straight down the abdominal region. Rectus meaning straight. Talked about that serrated anterior. You can't see it really well from right here, but it's right here. It originates here, 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 here. Ribs 1 through 10. And it looks like a serrated knife. Here it is right here also. Pectoralis major. And immediately underneath it is pectoralis minor. So pectoralis major, pectoralis major, pectoralis minor, deep to pectoralis major, and the serratus anterior. You can see right here, you can also see it right here. Also right here. So here we can see the external and the internal intercostals. Remember, the internals are going to make an A. And so here's the manubrium. Starting here, the fibers are running down this way. Meaning those are the internal intercostals. External intercostals are going to make a V going down like this.
Am I looking at that picture correctly, seeing the internal intercostals on the back of the rib cage on the dorsal side?
You know what? They're on the back of the rib cage. They're on the front of the rib cage. You're probably looking at it correctly, yes. But there's just what it's essentially saying is that there's two layers. There's the internal intercostals are the most inner layer. The external intercostals are the outer layers. And it's the same way for the external obliques, abdominal obliques, and the internal abdominal obliques. So external obliques originate on the surfaces of the lower 8 ribs. So we're looking at the abdominal wall and insert on the outer lip of the iliac crest and the linea alba. The linea alba is this line right here. The linea alba. So this is where it inserts the external oblique. Compresses the abdomen and flexes and rotates the vertebral column. Internal obliques are going to run in the opposite direction. They're going to originate on the iliac crest and the inguinal ligament and insert on the ribs, linea alba and pubic crest. And involving compressing the abdomen, flexing and rotating the vertebral column. Deep to both of the obliques is the transversus abdominis. And rather than the fibers running at an oblique angle, they're going to run horizontally. So they're going to originate on the cartilages of the lower 6 ribs and the processes of the lumbar vertebrae. And they're going to insert on the linea alba and the crest of the pubis, and also work to compress the abdomen. Rectus abdominis, that's your 8-pack muscle. Originates on the crest of the pubis and inserts on the xiphoid process and the costal cartilages of ribs 5 through 7. Also compresses the abdomen and flexes the vertebral column. So rectus abdominis, very deep muscle, transverse abdominis, so you can see that the fibers run horizontally. Internal obliques make an A. External obliques make a V. External obliques. Shift gears here. Oh no, I can't see what I'm looking at. So rectus abdominis, external obliques because it's making a V. Internal obliques because it's making an A. And transverse abdominis is moving horizontally. Questions? Muscles that move the arm. Oh, that isn't what I meant to do. So muscles that move the arm. Muscles that connect the arm to the pectoral girdle, ribs, and vertebral column. Flexors can include the coracobrachialis, meaning it's going to originate on the brachii. It's going to insert on the brachii and originate on the coracoid process. Pectoralis major. Extensors include teres major, latissimus dorsi. Abductors include the supraspinatus, meaning above the spine of the scapula. The deltoid muscle. And rotators are subscapularis, meaning it's in the subscapular fossa. Infraspinatus, meaning it's under the spine of the scapula. And teres minor. So coracobrachialis originates on the coracoid process of the scapula and inserts on the mid shaft of the humerus, flexes the arm at the shoulder, and adducts the arm. Pectoralis major originates on the clavicle, sternum, and costal cartilages and inserts on the intertubercular sulcus of the humerus. Where would that be? Where would that be?
On your leg?
Oh, we're looking at the humerus, so it can't be on the leg.
Sorry,
No, you're okay.
arm,
You know, welcome to my reality.
femur and humor.
Oh,
Okay, never mind.
You're all right. Where, you know, I can see Justin's like pointing to it too. Where is it, Justin?
So that would be at the top of the humerus in the dip in the center.
Yes. Okay, so it's in between the greater and lesser tubercles.
Yeah, those.
He's like telling them and he's not telling us. I get it. I understand how it works. Teres major originates on the lateral border of the scapula and inserts on the intertubercular sulcus of the humerus. Tessimus dorsi is going to originate on the spinous processes of the thoracic and lumbar vertebrae, iliac crest, and lower ribs. So like I said, it makes this whole thin muscle across the back, very superficial. And inserts on the intertubercular sulcus of the humerus, extending the arm at the shoulder and adducting, immediately rotating the arm. Supraspinatus originates in the supraspinous fossa of the scapula and inserts on the greater tubercle of the humerus and works to abduct the arm. Deltoid originates on the acromion process, the spine of the scapula and the clavicle, and inserts on the deltoid tuberosity of the humerus and works to abduct the arm and flex the arm at the shoulder. Subscapularis is going to, it doesn't say it here, but where's the anterior surface of the scapula? What's the bony marking that's on the anterior surface of the scapula? It's the bony marking that's on the anterior surface of the scapula. The subscapular fossa, if you remember, because when we're looking at the anterior surface of the scapula, here's your scapula right here. This is the back of your scapula, the posterior side, right? So the anterior side has to be this, and right underneath here, if we're looking at the scapula minus the ribs here, that's the subscapular fossa. So the subscapularis originates in the subscapular fossa and inserts on the lesser tubercle of the humerus. So some of these, if you can remember the name, you can remember some of the origins. Immediately rotates the arm. Infraspinatus originates on the infraspinous fossa of the scapula. So here's the spine. So the infraspinous fossa right here is where it's going to originate. And it's going to insert on the greater tubercle of the humerus, laterally rotating the arm. Teres minor originates on the lateral border of the scapula and inserts on the greater tubercle of the humerus. What are the muscles, rotator cuff muscles? They include supraspinatus, subscapularis, infraspinatus, and teres minor. You've heard of people damaging their rotator cuff. That's the muscles that support your shoulder. So rotator cuff, supraspinatus, infraspinatus, and teres minor, and subscapularis. You can't really see it. They've actually removed the spine, but the spine would be right here. But supraspinatus, infraspinatus, and if we're looking at the anterior surface, the subscapularis. I couldn't find a better picture of a cadaver that showed those muscles. So it is a little blurry, but I couldn't find a better one either. So I apologize. Here's your teres minor right here. And teres major would be underneath it. So shifting down, looking at the arm. The deltoid, biceps brachii, and deep to the biceps brachii is the brachialis. Biceps brachii is the prime mover for flexion of the arm at the elbow. Brachialis is a synergist of those, of the biceps brachii. So it's going to be involved in helping that flexion. Triceps brachii. Here's the pinky of the model. Here's the thumb of the model. So where's the ulna? Is it on the side of the pinky or the side of the thumb?
Isn't it the pinky?
It's on the side of the pinky, right?
Other one will be radius, right?
Right. And so the muscles that are on the back of your lower arm that are running on the back of your arm are extensors, because they're going to be involved in allowing you to, bear with me, I'm going to stop this. They're going to be the ones that allow you to extend your fingers. Extend your fingers, you see all your extensors coming out. So extensor carpi ulnaris. So this is what's going to extend your wrist on the ulnar side. Extensor carpi radialis is going to extend your wrist on the radial side. It's also involved, bear with me here. Just a sec, baby. So abdominal position. My extensor carpi ulnaris right here, if I use it and contract it, what am I also doing? It's a weak adductor, because it's actually going to move my wrist. When I do that, it's going to move my wrist towards my midline, right? It's going to be easier to see with the flexors. But if I do this, extensor carpi radialis longus, about right here. When I do that, I'm moving my hand away from my midline. So it's also abducting my wrist. It'll be clearer in a second here. It's not clear right now. Come here, baby. Hey, phasers, come here. My teaching assistant lost her position on my lap here. So brachioradialis is going to insert on the humor, excuse me, originate on the humerus right above the lateral epicondyle and insert on the spinous process of the radius. And I can know that just by looking at the name alone because of the brachioradialis. So the triceps has 3 heads. The long head, it has a lateral head. And it has another head that isn't shown here, medial head. And it's going to insert on the olecranian process, I think, of the ulna. Looking here. Oh, Louie, buddy. Louie, hey, Louie. Is the threat gone? Probably. So teres major, teres minor. Here's the medial border of the scapula. So infraspinatus, corner of the trapezius, the deltoid muscle, biceps brachii. And right here is the ulnar nerve that's going to come down and go underneath the medial epicondyle. I mean your funny bone nerve that's not so funny. And the latissimus dorsi. And the top of the origin of the brachioradialis. So now looking at the anterior part of your arm. Posterior extensors. Therefore, on the front of my arm, flexors. Posterior is extensors. Front is flexors. Egg. Yeah. Brachioradialis. Pronator teres. What do you think pronator teres allows you to do? What do you think your carries allows you to do?
Allows you to rotate so you can your palm or lower it.
What is that called when you rotate it that way?
Pronation.
Yes, yes. Allows you to pronate your arm. Down below, so there's a pronator teres up here. Teres means cylindrical in shape. So if you look at like teres minor and teres major, they both look cylindrical in shape. Pronator teres also look cylindrical in shape. There is another muscle about right here that makes like a triangle, not a triangle, a square that's called pronator quadratus. And they both work to pronate your hand, pronate your arm. So flexor carpi radialis, flexor carpi ulnaris, flexor digitorum. Oh, flexor digitorum profundus and superficialis. All of them are going to originate on the medial epicondyle. So many of your flexors for your wrist are all going to originate off the medial epicondyle. Your extensors will originate off the lateral epicondyle. So muscles that move the forearm. Most forearm movements are accomplished by muscles that are actually, do you guys want to take a break? Let's take a break. We will finish early tonight, but let's take a break right now. Let's come back at let's say 7:45. Mom, can he be in here with you? What? Okay. What? Yeah, am I missing the point, Amherst? All right, let's come back. I think I said about right now, so I think let's come back about right now. So muscles that move the forearm. Most forearm muscles are accomplished by muscles that arise from the humerus or pectoral girdle and connect to the ulna and the radius. Muscles on the anterior side of the humerus are going to cause flexion of the elbow. And muscles on the posterior side are going to cause extension of the elbow. Flexors tend to be the biceps brachii, the brachialis, and the brachioradialis. The major extensor is the triceps brachii. Rotators include the supinator, pronator teres, and pronator quadratus. Biceps brachii originates on the coracoid process of the humerus, coracoid process of the scapula, and the tubercle above the glenoid cavity, and insert on the radial tuberosity and flexes the forearm at the elbow. Also is a weak supinator of the forearm at hand. Brachialis is going to originate on the anterior surface of the humerus and insert on the coronoid process of the ulna and flex the forearm. The brachioradialis originates on the distal lateral end of the humerus and inserts on the lateral surface of the radius. Triceps brachii is going to originate on the tubercle, the inferior surface of the glenoid cavity on the scapula, the lateral surface of the humerus, and the posterior surface of the humerus, and insert on the olecranian process of the ulna. How do you know if you know that it's a supinator or a pronator? What bones are you moving when you supinate or pronate your arm? What bones are moving when you supinate or pronate your arm? What bones are moving? What bones are moving when you supinate or pronate your arm? So supinate or pronate your arm. What bones are moving?
It would have to pull on the, well, no, the radius. Well, wait,
He's testing here.
I don't know.
He's doing good. Thinking through it.
You're good.
Okay, Justin, grab your, so bear with me. My apartment is cold tonight for some reason.
It's very cold outside and windy.
It is.
Yeah.
So we're in. Bear with me here. So Ivy, do this with them and make sure they do it right, all right? Other way, grab your elbow, grab right here, bottom part. And now, so right now you're in the supination. Now pronate and tell me which bone moves.
It's one on the outside. It's whatever.
Yeah.
Is your all, if you grab your elbow, Ivy, you're grabbing your ulna. Does that bone move when you
No,
when you turn it over? It
No.
doesn't, so that's not moving.
the radius moves.
Right, the radius is gonna move.
Yeah, because
There.
outside
You learn something new
that
every day.
moves.
Yep.
Yeah.
And
Well-
it's the best way to learn that. So if the insertion point for whether it's a supinator or a pronator has to be on the radius because that's the one that's moving. The origin is going to be on the ulna or the humerus. But it's going to be on the ulna. So pronator teres and pronator quadratus. Pronator quadratus is on the distal end of the ulna. And the insertion point for it is the anterior end of the radius. The pronator teres is going to be up towards the proximal end of the ulna. And it's going to insert on the radius. So all of the supinators and all of the pronators are going to insert on the ulna, originate on the ulna and insert on the radius. So coming down a little further, extensor carpi longus. Here's my pinky, here's my radius. So all of my extensors are coming off the, bear with me, I want to make sure. They're coming off the medial epicondyle. The flexors are going to come off the lateral epicondyle. Am I right? Yeah. Medial epicondyle and then lateral epicondyle for flexors. So extensor carpi radialis longus is going to come off right on the superior, right above the epicondyle on the humerus, the lateral epicondyle. Extensor carpi brevis is a little shorter, and it's going to come down underneath it and be deep to it. Extensor digitorum extends all my digits. It's the one that you see on the back of your hand. So when you extend all of your digits, you see it right here. See it right here. Extend it, Sherry. Yeah, you see it right there. Yep. Booyah. Yep, that's it. Extensor carpi ulnaris, extensor digitorum, and extensor digiti minimi. What do you think extensor digiti minimi does?
Your pinky.
Yeah, it does your little finger, your digiti minimi. So just looking at it on a cadaver. Brachioradialis, extensor carpi radialis longus, extensor carpi radialis brevis, extensor digitorum, extensor carpi ulnaris. Looking at the flexors. Here's the insertion point for the biceps brachii on the radial tuberosity. Here's the thumb. So brachioradialis, flexor carpi radialis, coming down to the radius. Palmaris longus. Palmaris longus is the one that you can see the tendon for when you do this. This one right here. See that the tendon inserts on the skin of your palm. Very weak flexor, as Marissa's dog is feeling neglected. So looking on this other side. Coming off the, excuse me, the lateral epicondyle, flexor carpi radialis, pronator teres, flexor carpi radialis brevis, flexor carpi radialis longus, palmaris longus, and flexor carpi ulnaris, all coming off the lateral epicondyle, originating on the lateral epicondyle. All right, this is so my niece, who is, how old is my niece now? She's 15. But this last summer, and I know that this is kind of blurry, but this is the best I got. She decided about last July to put her finger through a plain glass window. And they live in a very old home, this home that was built in like the early 1900s. And she was roughhousing with her brother. And as they were running from one room to the next room, she ran after him and ended up putting her finger through the window. And of course, because her aunt loves anatomy and physiology, my first thing was, okay, what did you cut? What did you damage? I had to know this. And when she went in, this is what they sutured initially. But then they also realized that she could not fill anything up here, and she couldn't bend her fingers. She couldn't flex her fingers. And there's a 24-hour, what is it? No, it's not 24 hours, 3-day window between when you've damaged a tendon and a nerve to the point of where you can't repair them. They're irreparable. And so she was in to surgery a day later. And this is what it looked like afterwards. So this was before the surgery. This was just to stop the bleeding, so she was stable for 24 hours. This was afterwards. And what she did is she cut, from what I understand, she cut her flexor digitorum profundus tendon and her flexor digitorum superficialis tendons, because she could not flex up here. From right here, she could not flex. You can see she's got them flexed there, but she could not flex up here. She also severed her, was it her median nerve? She severed her part, I think it was her median nerve. And she severed it about 90%. Whether or not she'll ever get feeling back in this part of her finger, they don't know. Because she did it at about, she severed about 90% of it. And my first question when I'm looking at these pictures, because I didn't take these pictures, they sent them to me because I was like, I want everything. I want the notes, I want everything. Figure out just what she did. But why, if this is what it was before surgery, why does it look like this afterwards? Why did they have to go so deep down into her hand? That was my first question. Why do you think they had to go so deep down into her hand?
Did the tendon retract?
It did. And see, I didn't know that it would do that. The tendon retracted, and so they had to go down and get it. So then I asked for, so I got the pictures, and then I asked for the doctor's notes. And I'm going to read these to you. It says, so there was a suture of, now I can't even read that one. Suture of nerve on hand or foot. The first nerve right repair, advancement of the flexor tendon, so bringing the tendon back up on zone 2 of the digital flexor tendon. And it says a sheath ligament, no man's land. I'm going to try to zoom out and maybe I can read it better than I'm reading it right now, because I know I was able to read them initially. So suture of digital nerve, hand or foot, first nerve, right repair or advancement of the tendon in zone 2 of the digital flexor tendon sheath. It was in no man's land, and it was without a graft. They didn't need to do a graft for the tendon. So my first question after was, what in the world is no man's land? And so I went online and I put in no man's land in zone 2. And what it did is it brought up this diagram right here, showing zone 5, zone 4, 3, 2, and 1. And historically, this was a spot where they would not do surgery because the amount of scar tissue and the amount of healing that occurred afterwards meant that you lost more flexibility just from post-op. That's why it was called no man's land. They would, if she'd done this 100 years ago or 50 years ago, they wouldn't have tried to repair it, because the damage to her flexibility and her abilities to utilize her hand would have been worse after surgery. And the tendon that she cut, right here, you have this flexor digitorum superficialis that comes and inserts on the middle phalanges. And underneath it is flexor digitorum flexor digitorum profundus. So this FFDS and FDP is flexor digitorum superficialis, flexor digitorum profundus. So flexor digitorum profundus is the ones that you can almost see on your hand. And then flexor digitorum profundus comes through a split of superficialis and inserts on the distal phalange. So my guess is, looking at her hand, she nicked part of the tendon on the superficialis, because it looks like she cut it about right here. She did part of the superficialis and part of the profundus. And I thought that was neat stuff, and I asked if I could share it, because I was like, that's just cool. It wasn't so cool for my niece, but it was cool for me. But when I saw her, I told you I went down to Virginia. I don't know if I told you I went down to Virginia, but I went down to Virginia about 2 weeks ago, a week and a half ago. And I saw her, and she has very little scarring. I was pretty amazed that she has as little scarring as she has, because I could barely even see where she'd done it. But it was, I think it says here, she did this in July 27th was when they did the surgery. And she was in physical therapy until November. The guy, her physical therapist, said that if she really wanted to damage her finger, she couldn't have done it any, this was a good starting point for getting good injuries, because it was 5 months of physical therapy. But then her brother, ironically, her brother that decided that she was going to chase him through the house when she put the finger through the plain glass window, cut his tendon with a machete about a month and a half ago. And we just, it's too funny. It's funny now. It wasn't funny then. My nephew learned why there were so many nerves in your around your bone, in your excuse me, periosteum, because when he cut the tendon, he nicked the bone, and learned that it was an exceptionally painful recovery because he nicked the bone. It's not the tendon that hurts, it's the bone. But yeah, so any questions that I may or may not be able to answer? Yeah, I thought it was a very cool injury. I was like, okay, so what did you do? So I got everything that I possibly could get. And that this is essentially a photo of the doctor's notes that my sister-in-law sent me. So now that you're learning all this stuff about anatomy and physiology, even looking at a doctor's notes, which this is essentially what they give for insurance purposes, you can understand a major part of it, what they're doing and what they did. So flexor carpi ulnaris, remember all of your flexors coming off the medial epicondyle. So flexor carpi radialis is originating off the medial epicondyle. Flexor carpi ulnaris is coming off the medial epicondyle and the olecranon process of the ulna. Palmaris longus is originating off the medial epicondyle. Your extensors are coming off approximately the lateral epicondyle. Flexor carpi radialis inserts on the base of the third and fourth metacarpals. Flexor carpi ulnaris is inserting on the carpal bones in the fifth metacarpal. Palmaris longus is going to go to the fascia of the palm. And the flexor digitorum profundus, that one that splits, this one right here, this one right here, coming up and inserting on the distal phalange. Flexor digitorum profundus, flexor carpi radialis longus, originating on the lateral end of the humerus, distal end of the humerus, and inserting on the base of the second metacarpal. Extensor carpi radialis brevis, originating on the lateral epicondyle of the humerus and inserting on the third metacarpal. Extensor carpi ulnaris is also going to come out to the originate on the epicondyle and insert on the fifth metacarpal. Extensor digitorum lateral originating on the lateral epicondyle and inserting on the second phalange on fingers 2 through 5. No, it's not 2 through 5. It's a distal phalange. I'm sorry, 2 through 5 distal phalange. I got it mixed up with the flexor digitorum superficialis. Extensor digitorum is going to extend the wrists and the joints of the fingers. So this is what I was trying to explain before, and I didn't do a very good job of it. But looking right here, do that. In anatomical position, if I flex my flexor carpi ulnaris, I'm bringing it towards the midline, right? My wrist. Therefore, I'm adducting my wrist when I use my flexor carpi ulnaris. So I'm flexing my wrist, but I'm also adducting my wrist. If I flex my flexor carpi radialis longus and flexor carpi radialis brevis, I'm flexing my wrist, but I'm also abducting my wrist because I'm moving it away from the midline. If it helps you to remember those, that's the way I remember it. Because if you're in anatomical position and you work really hard at flexing those things, you can see that you're abducting or adducting your wrist. So muscles of the posterior hand. Extensor carpi radialis longus. Extensor carpi radialis brevis. Extensor digitorum. Extensor digiti minimi. And extensor carpi ulnaris. All coming off the lateral epicondyle. All originating off the lateral epicondyle. This extensor retinaculum down here, I know it's kind of blurry. Extensor retinaculum, this is the retinaculum that they make little nicks and little cuts in it when they try to repair carpal tunnel syndrome, because it wraps around the carpals and the median nerve. So they make little nicks in it to try to alleviate the pressure on the median nerve. It's actually more of a carpal retinaculum because it surrounds the whole entire wrist. So moving down, muscles that move the thigh. Gluteus maximus is your major butt muscle. Originates on the sacrum, coccyx, and posterior surface of the ilium, and inserts on the posterior surface of the femur and fascia of the thigh, extending the thigh at the hip and laterally rotating the hip. Gluteus medius, which is underneath it, is on the lateral, originates on the lateral surface of the ilium and inserts on the greater trochanter of the femur and abducts the thigh, medially rotates the thigh. Gluteus minimus is on the lateral surface of the ilium, originates on the lateral surface of the ilium and inserts on the greater trochanter of the femur and abducts the thigh. Immediately rotates it. If you abduct, never mind, I was going to say something and then I realized it was wrong. Tensor fasciae latae is a really tiny muscle that originates on the anterior iliac crest and inserts on the fascia of the thigh. And also works to abduct, immediately rotate the leg. Adductor longus allows you to adduct the thigh. It originates on the pubic bone near the pubic symphysis and inserts on the posterior surface of the femur. Adductor magnus allows you to adduct the thigh and extend the thigh at the hip. Gracilis is a very, very tiny muscle, most medial superficial muscle on the internal surface of the thigh. So it originates on the lower edge of the pubis and inserts on the medial surface of the tibia and abducts the thigh and flexes the thigh at the hip and medially rotates the thigh and leg. So gluteus minimus, gluteus maximus, the big muscle. The iliotibial tract. We don't see it here, but tensor fasciae latae is right here. The iliotibial tract runs from your ilium to your tibia. It's kind of like the cranial aponeurosis, epicranial aponeurosis. Major sheath of dense regular connective tissue. Biceps femoris. Semitendinosus, semimembranosus. here's your hamstring muscles, semitendinosus, semimembranosus, and the gracilis muscle right here. Adductors, bring it out, you contract them and you bring the leg back in from that, from being abducted. So here's your iliotibial tract. Semimembranosus, that's deep to semitendinosus. Gluteus maximus and biceps femoris. So gluteus maximus, tensor fasciae latae is about right here. Adductor magnus works to adduct the leg. Semimembranosus, semitendinosus, and biceps femoris. Why does that not look right to me? Bear with me just for a quick moment here. Because I thought the tensor fasciae latae was in a different spot. And looking at that picture, it doesn't look right, what they're telling me it is. So they're telling me that the picture that we're looking at right there is telling me that the tensor fasciae latae is down here. But I know that it's up here. On the models that I've seen, it's up here. So I'm not sure what that picture is trying to show. Bear with me, I'm going to come back to it. Because it's showing it right down here. And that doesn't look right to me. But it's got to be more up here. It's up here. Yeah. I honestly, I got these pictures. I like showing cadaver pictures, but that just doesn't look right. Everything else looks right except for that. Gracilis, really most medial muscle that runs straight down the leg. On the front of the thigh, vastus lateralis, underneath the vastus lateralis, excuse me, right next to vastus lateralis, underneath rectus femoris, is the vastus intermedius, and then vastus medialis, and gracilis and sartorius. Sartorius allows you to cross your legs. Used to be the tailor's muscle, and that's where sartorius comes from, the word tailor. Sartorius is some language for being tailor, allowing you to cross your legs. If you remember looking at tailors from a long time ago, they would, when they were going to hem someone's pants or their skirt, they would sit cross-legged on the floor and do it. That's where the name of that muscle comes from. But it's the longest muscle in the body. Going from the anterior iliac spine down to the medial edge of the tibia. So muscles that move the leg, sartorius goes down to the proximal medial surface of the tibia, flexes the leg at the knee, flexes the thigh at the hip. Abducts and laterally rotates and medially rotates the leg because it allows you to cross your legs. Biceps femoris flexes the leg at the knee and extends the thigh at the hip. Semitendinosus and semimembranosus originate on the ischial tuberosity and flex the leg at the knee. Quadriceps femoris all work to extend the leg at the knee. So vastus lateralis underneath, right next to it, underneath rectus femoris is vastus intermedius and vastus medialis, and these are your quads. The four of these are your quads, quadriceps. And they all insert via the quadriceps tendon on the tibial tuberosity. Towards the bottom of the leg, the gastrocnemius and the soleus muscles work to plantar flex the foot. Fibrialis longus, allowing you to abduct your foot. Extensor digitorum longus, extending out the digits. Tibialis anterior, allowing you to dorsiflex your foot. Both the gastrocnemius and the soleus are going to insert on the calcaneal tendon or the Achilles tendon. They're going to insert on the calcaneus via the calcaneal tendon or the Achilles tendon. Allowing you to plantar flex, meaning flex your ankle via the calcaneal tendon. So gastrocnemius soleus. Gastrocnemius, because it's got two bellies. Can't see it very well on this one. You can see it better on this one. Here's one belly, here's the other belly. Tibialis anterior, digitorum, extensor digitorum longus. Tibialis anterior, this is the one that you get shin splints from. When you've been walking around with things that are too heavy on your feet to the point of where you're overly dorsiflexed your foot, the tibialis anterior muscle will pull away from the anterior border of the tibia, causing shin splints because you've inflamed this muscle. So tibialis anterior originates on the lateral condyle and lateral surface of the tibia. It's going to work to dorsiflex and invert the foot. Fibularis longus or fibularis tertius, they're both going to work to evert or plantar flex your foot. extensor digitorum longus, dorsiflexing your foot, and extending the lateral toes. Gastrocnemius plantar flexing the foot and flexing the leg at the knee. Soleus plantar flexing the foot. Flexor digitorum longus, flexing your four lateral toes. Looking at them one more time. Fibularis longus, allowing you to evert your foot and flex your ankle. Evert, remember evert meaning to take it, move it away from the midline or move it out. Invert meaning to bring your foot in towards the midline. Looking at one more view of it. Gastrocnemius, the two bellies, and the calcaneal tendon, and the soleus. The soleus looks like a flat fish when you separate it from the gastrocnemius. That's because sole means fish. It looks like a fish. Picture of a model with the muscles of the leg. Do you have any questions for me? Hey, this is our last night of class, so I wish you good luck with all your finals. And let me know if you have any questions. Email me or text me or something. And congratulate yourself because you made it. That's important too.
Thank you. Have a good night.
You too.
Thanks for everything.
Of course. Max, why aren't you becoming a doctor?
I don't want to.
Why not?
Because that's way too much of a commitment.
Okay. All right. I had to ask. I had to ask. I've been thinking about it. Had to ask.
I did want to.
I know you did. And so I was like, why isn't he still doing it? All right.
I value my 20s.
Oh, okay. I understand a little bit.
Michael was going to do the same thing, and he actually started his first year in pre-med, and the commitment is insane, and he decided the same thing. So he's just going to do advanced practice nursing. It can get him as close as he wants to be without losing your entire life.
Yes, and my mother's here
And
to
I
give
can
her
tell you that
input.
it can be very rewarding.
Absolutely.
You don't have to, and I told my son when he was looking at it, I said, you'll spend a third of your life going to school. And then if you ever want to have a break, you'll have to leave town.
Exactly.
So yeah, it can be consuming to
Yeah.
Position. It can be consuming to be advanced practice nurse if you don't keep it balanced.
Yeah, I have one that is looking at, Alan is looking at nurse practitioner. That's his goal. Michael wants to be an RNFA in the OR. And I'm going into aesthetic nursing. So crazy.
That's anesthesia, correct?
Yeah.
No, so that's all cosmetic.
Oh, yeah,
okay,
see,
okay,
that's
all
up
right,
his
that's
alley.
what I'm trying
He's
to.
got it.
Yeah,
He's gonna love
is it that nurse anesthetist? And
Yeah, I was.
no, and well, and there's a crying need for that out there.
Oh, absolutely. I was in the beauty industry for 22 years. And so I understand the profound impact that it has on people. And this is a way to just take it the next step.
And I'm going to reap all the benefits.
There you go.
That's small.
Well, you know, let me know when you're ready. Maybe you can benefit me.
Not a problem.
All right, best of luck to you.
Thank you. Professor Gessel, thank you for everything.
Of course, I've enjoyed it. You guys have been a great class.
And
I can't say that of all my classes, I can tell you. So you guys have been a great enjoyed it.
It's been a good.
Oh, sorry. I was just gonna ask, are you gonna be teaching any more at Hack? Like
I will, whether I'll be teaching online or not. Right now, I'm set up to teach 2 face-to-face classes, and they're both 121. I want to teach more online, but I also I need the experience of teaching face-to-face for Hack, which I have not had. This will be I'm teaching face-to-face for Hack for the first time this summer, which is going to be a good thing because I need the time to adjust and not be teaching at 3 schools at the same time, which means I'll never adjust if I try to do that. But I will probably, if I'm offered another class at I know I'm teaching face-to-face at the Gettysburg campus this summer and face-to-face at the Gettysburg campus next fall. And you guys are all so far away from where I live. Are you in Harrisburg or Lancaster?
I'm closer. I don't know. I'm on the West Shore. I'm like Camp Hill, Mechanicsburg.
Where's, okay, I know where that is.
Mechanicsburg as well.
Okay.
Same.
Yeah.
Yeah.
Yeah,
I'm south of York, so this was just quite convenient having it virtual.
yeah, I agree. And I've liked teaching virtual. Like I got hired during the pandemic, at the very beginning of the pandemic. And so I've only taught online for Hack. And so it'll be an interesting experience for me. But yeah, I will be teaching more. I just don't know what. But if you're looking, if you're wondering about recommendations for professors, let me know and I'll give you my best input for what I know about who I know, which isn't a lot.
I was just curious because there's like only a couple of online classes, but they don't have professors assigned for 122 for the fall. So I didn't know.
They don't?
At least when I checked it like a week or 2 ago, didn't have anybody named for like a similar class to this time frame. So I kind of wanted to take it again just because of my schedule and I have 3 kids and stuff. But I was like hoping maybe you were going to take one of those.
Remember, bear with me, I'll look. I can't remember. I may have a class during this time next semester that I'm teaching at Carroll, and I don't remember. I write them down because I can't ever remember what I'm doing sometimes.
Yeah, it may have been like a Tuesday, Thursday, but it was definitely like a 6 to 9 or something similar.
You know, I'm teaching that time at Carroll, Tuesday, Thursday. Monday, Wednesday, I'm not. But yeah, if they offered me that and if it wasn't a time that I could take it, I would do it in a heartbeat. And I'd be a better teacher than what Zena struggles with right now with 122. Because I can tell you this is like my 5th, 6th time teaching 121. This Zena is struggling through my first time teaching 122. So, and I'm not as organized as I have it down here, which you may not think is organized, but it's much better than what 122 is.
So we will not have So this is our last full lecture. We won't have lecture on Monday.
Nope. No, we won't. If you need something, know that I'm available.
Well, question about the comprehensive final. I mean, do you have any idea like how many questions there are or how much time we
I
need
think
to
it's
allot?
120 questions or somewhere right in there. There's been people who have already taken it. And I think it's easier because I tried to pick general questions. Yeah, I tried to pick more general questions, but I tried to make them wide spanning. So they're over the whole myriad of topics.
They were 126 questions.
Say it one more time.
126.
I honestly, was it 126?
Yeah, I already took it.
Okay. Yeah, I don't, honestly, I put it together a while ago.
I'm gonna hop off, but wanted to
Okay.
say thanks and wish everybody well and take care.
Yeah.
Liz.
You too.
You too.
Thank you for the eye dissection.
Oh, that was awesome, Ivy. And I'm so glad you brought it up because I think it was good for everybody. I wouldn't have done it. Your dad can tell you I wouldn't have done it if you hadn't brought it up. So I'm glad you did. I wasn't planning on it until you said that was your favorite.
Thank you so much.
Of course.
I have a question. When are we getting our scores for the case studies?
Say it one more time.
Where are we getting the scores for the case studies?
As soon as I have time to grade them.
Okay.
Which I can't say is going to happen this weekend. It will be next week.
All right.
I need to make time to grade them, and it will happen next week. It might happen this weekend. Let me just see what happens.
Thank you.
Of course.
Great, thank you, Professor. I'm not feeling so well, so I'm gonna sign off, but thank you for everything.
You're welcome, of course.
Good luck, everyone.
Thank you. Good luck to you, Max.
You
See you
too,
guys.
Max.
Bye.
Bye.
Thank you, Professor Gessel. Take care.
Of course, you too.
Thanks for everything. That was intense, but it was fun.
So intense.
Well, you know what? I think everyone, I don't know how people do it hack with AMP because I'm realizing all of my students who stay with it tend to do really well. I mean, the people who don't stay with it and don't do the work don't do very well, shockingly. But if they stay with it, the average grade in this class is an A. And I don't know if I'm doing something wrong, but my mother keeps telling me that I'm doing it right. So we'll see.
Well, and I think too, without, to be honest, and I know especially because we have so many people around us that have taken A&P in a bunch of different ways.
Right.
Anatomy separately, physiology separately, chemistry separately. And like even Alan and Michael seeing the way that we're taking it, they're like, this is incredibly difficult. It's so much information at once. But I know for the three of us, like for Marissa and for Mom and I, we at least support each other in it, which helps a lot, but it's still been really intense.
It's a lot.
Yeah.
I agree. I agree.
Micro, which I hope is no more intense than A and P.
I don't think it's just, if it's like it is at Stevenson, it's not as intense.
I hope not. I really hope not.
What
I
are
was
you guys
talking to you?
What are you guys looking at? Are you doing the